Happy to be here. I'm excited. Well, I guess excited, a little bit of trepidation about what's coming in the coming months for those of us engaged in international research. Want to acknowledge that we're all probably a bit reeling from all the announcements last week about subawards and how we're going to do research in these settings. I know I'm personally affected by that. But we can take the time today to talk about my projects and introduce you to work that I do and love to become more involved and with collaborators here at UCSD. So this is an overview of the work that's mainly my international work. So I do a lot of work with anal cancer prevention, but most of that work is really domestic. So I'm not really going to talk about that so much today, but efforts around cervical cancer screening for women with HIV in low and middle income countries, as well as some efforts and projects around HPV vaccination. Here are some disclosures. So when we talk about cervical cancer, for women worldwide, breast cancer is certainly the most common cancer, and in many places, one of the more common or the most common cause of cancer death. For low and middle income countries, and especially for women with HIV, it's really cervical cancer that is the more common cause of cancer death in low and middle income countries. And this is despite the fact that we have an effective preventive vaccine and despite the fact that we have tools to screen and treat precancers of the cervix to reduce cervical cancer. When we look at the incidence of cervical cancer worldwide, this should remind you of the map of HIV incidence. So really this incredible hotspot of cervical cancer incidence and mortality in sub-Saharan Africa, similar to what we see for HIV incidence. So these are kind of overlapping and synergistic epidemics. So there's a great variability of cervical cancer screening uptake around the world. So in areas of the world where there are effective screening programs, you see the importance of cervical cancer as a public health problem diminishing. So over the decades, as screening programs have evolved, more women have become screened and more pre-cancer treatments have been implemented, the rates of cervical cancer in those areas have gone down. However, many parts of the world really don't have effective cervical cancer screening programs. And so here's a variety of countries here, and you can see at the bottom, Kenya, that a country that I'm currently working with through the Cascade Network, only about less than 20% of women of screening age have ever had any kind of screening activities, highlighting that really the great challenges we have to really bring screening on a widespread basis. So a lot of what we're going to talk about is how do we simplify cervical cancer screening to allow it to be to have a greater population level benefit. So when we talk about HPV, it's a very interesting virus. So it's evolved with humans over millions of years, and there are just hundreds of different types of HPV. In general, the more sensitive a test you look for, the more HPV you find. There's HPV all over our bodies, but really when we're talking about cancer or cervical cancer, especially we're talking about sexually transmitted types of HPV. So there are about 40 different types that infect the genital tract, and about 14 of them have been designated as high risk or cancer-causing types of HPV. So traditionally, we think of HPV as a problem for women, but of course, it affects both men and women. The two most common types for causing cancer are types 16 and 18. They're responsible for about 70% of HPV-associated cervical cancer. And we'll talk a little bit about natural history of HPV, but the vast majority of HPV infections are just cleared and never become a problem. It's really only a small minority of HPV infections that can really have persistent infection and have the potential to cause cancer. And I think one incredible statistic is that HPV is known to cause about 5% of human cancers. So it just shows that if we are able to implement HPV vaccination on a widespread scale and implement effective cancer screening programs, we could make an appreciable dent in human cancer morbidity and mortality. So we're going to talk about the cervix, just a brief primer. So this is the cervical os. So you insert a speculum and you look for the cervical os. So if you see right here, there's this line. So there's two different types of epithelium. Towards the middle, this goes up into the uterus, is the columnar epithelium. And here, this line that you see is the squamo-columnar junction. It's this junction where HPV infects most readily, and where the cervical precancer and cancer typically develops. You can see here the histopathology on the left, this to the right, excuse me, to the right, upper right, here you see the stratified squamous epithelium, and beneath us is columnar epithelium. And this junction is where the HPV typically infects. So as far as a primer of HPV, so you have the epithelium. Here at the bottom are these basal epithelial cells. These are the targets for HPV. It's thought that HPV infects through these like micro breaks in the skin and attaches to these basal cells. And over time, the HPV can enter the cell and infect the cell. When it replicates, it can cause these dysplastic or abnormally dividing cells. And we grade this, the amount of dysplasia by how far through the thickness of the epithelium these dysplastic cells extend. And so when they extend to the middle third and the upper third, we call this precancer. And when the cells actually invade the basement membrane is when someone has invasive cancer. So when we think about how this is impact, if we have antibodies against HPVs, particularly antibodies that are the result of HPV vaccination, the antibodies can bind the HPV before it enters the cell and stop this whole process. We have innate and adaptive immune responses that can take areas of HPV infection and clear them. And then there's a number of exogenous factors, specifically for people with HIV. So lower CD4 counts really promote this process of oncogenesis. Antiretroviral therapy, we think, can kind of halt this. And certainly there's other factors such as tobacco, which can promote this HPV disease. So when we think about the pathogenesis, so we have this normal epithelium that becomes HPV infected, and it's these areas of HPV infection that can either just clear or it can actually progress to high-grade lesions, and these untreated high-grade lesions can eventually progress to invasive cancer. So women with HIV compared for women with HIV compared to women without HIV, they have a higher HPV acquisition. And so we don't really know if this is because they're exposed to more types of HPV, if there's something about their cervix that makes it more likely that they'll acquire HPV, or are they just less likely to clear HPV, which we know to be the case, and that's why we're more likely to detect it. But regardless, women with HIV have a higher prevalence and higher persistence of this high risk or cancer-causing HPV. And so that leads to a higher incidence of high grade, they're much more likely to progress to high grade lesions. And once they have high grade lesions, they're less likely to return to normal. And among those without that are not on ART, they are, or those on ART are likely to have a lower prevalence of HPV, so it does impact it somewhat, and it seems to protect against incident HSIL and really protect against development of cancer. Um, so the for women with HIV, for cervical disease, it gets complicated because they're much more likely to have multiple types of high-risk HPV detected. And the rates of cervical cancer can be 3 to 5 times higher than HIV negative women. And one issue that's really hasn't gotten a whole lot of attention is that when you do screen women with HIV with various tests, they tend to have precancer lesions that are much more extensive and much more difficult to treat. So they have a higher prevalence of disease, and then the treatments for that pre-malignant disease are less effective. And so even if you have women are engaged in screening more regularly, it can be more difficult to actually prevent cancer because they don't respond to the treatments as well. Um, so we're going to talk about the cervical cancer prevention. So of course, we'll talk about HPV vaccination later if we have some time, but in 30 to 40 years, if we had complete coverage of HPV vaccination with HPV vaccine, cervical cancer would cease to be a public health problem. However, the vaccine programs are not rolling out very effectively, and we still need to deal with the morbidity and mortality from cervical cancer for women that are, acquiring or developing cervical cancer at this moment. So when we talk about cervical cancer screening tests, there's kind of 3 large buckets. So the first one is Pap smear. So this is a cytology based test. So this is what our first cervical cancer screening test developed decades ago, and really in areas where they had effective screening programs and women could get multiple Pap smears, there was really an opportunity to to diagnose and intervene upon premalignant lesions and really bring down the rate of cervical cancer. However, cytology programs, especially in low and middle income countries, are very hard to maintain. It takes a fair amount of equipment. There's quality that needs to be maintained over time, lots of different reagents to do the stains, the personnel and expertise to read effective or have high quality cytology tests. And just fundamentally, it's a tedious. You look at a slide of different cells, and you're looking for sort of occasional abnormal cells, and it's really hard to execute in a uniform manner. Then there are, in low and middle income countries, there's visual inspection with acetic acid. So this is doing a speculum exam, looking at the cervix, applying acetic acid, which reacts with the skin to make areas of HPV damage show up. And so the advantage of this is that you are doing a speculum exam, you see lesions. In some cases, you're looking through an instrument that can also treat the woman. And so if you see the lesions, you can just implement a treatment right then and there to hopefully reduce her risk of developing cancer. However, like cytology, this is a subjective interpretation. And one of the major issues with VIA as a screening test is, one, it's inherently inaccurate, but then maintaining a reasonable level of accuracy and quality can be difficult to maintain over months, years, and over hundreds of different screening sites. So worldwide, the test that's emerging as the really most accurate and promising cervical cancer screening is direct molecular testing for HPV DNA, or in some cases RNA. And so the main challenge for this is really expense and access for low and middle income countries. I think some of the issues around costs are coming down, but it generally can't be used in a screen and treat approach, There is an exception with HPV, with the expert HPV test, which, you can run a test and get a result in an hour. So you could theoretically do same day test and treat for expert HPV. Overall, traditionally, cervical cancer screening is this multi-step process. So you have this target population, and really at a critical part of this is really engaging women in screening. So bringing them in for a primary screening test, or in some cases, bringing the primary screening test to the woman. But there's a primary screen, and then generally, if there's a screen positive, there's some sort of diagnostic evaluation to see if the woman has cervical precancer. And then if she has precancer, there's a treatment. So this is really a multi-step process. And as we know from any multi-step process, from HIV care and treatment, whatever, this multi-step cascade, there's opportunities at each step to lose women and to really lessen the impact that you have. One critical thing that I don't know that gets enough attention is it's not so much number of women screened that matters, that's going to reduce the risk of, or the rates of cervical cancer. It's the number of women that get treated, the number of women that have precancer that undergo a treatment. That is where you actually get the impact on cervical cancer mortality. So yes, certainly we want strategies to engage women in screening and to increase our numbers of women screened. But if the women that have precancer don't actually get treated, then you're really not making an impact. So we see this with PEPFAR numbers, for example. They report all these hundreds of thousands of women screened, but if you look at the proportion of women that actually undergo a treatment, it's like vanishingly small. So despite large numbers of women being screened in these programs, they aren't really going to make an impact on cancer. So a way that we try to simplify this is to use screen and treat approaches. So you engage women in the primary screen, and in the case of VIA, you do the VIA as your screening treatment, you see lesions, and then you implement immediate treatment so that you could have, once a woman is there, there's really like less opportunities to lose the woman along the cervical cancer screening cascade. And on the right is an example of this thermoablation that is the primary treatment used in this type of setting. We talked about cytology-based screening. So you screen with cytology, you have to get a colposcopy, and then you come back for a definitive treatment. So can we do this in a one-visit approach? So with the VIA. So a lot of the work that we're working on with our various projects is about HPV test and treat, because we think for a number of reasons that this will be able to be scaled up and be more effective and higher quality. So one of the central problems we have with HPV is that, clinical HPV tests in these settings, anywhere from 30% to 45% in sub-Saharan Africa, women living with HIV will have a positive HPV test. And so it would be very, very difficult to treat all of these women with these cervical treatments. So one of the areas that we're really working on is how do we triage women that have a positive HPV test? How do we decide amongst the women with this infection, how do we decide what proportion, which subgroup of them would benefit most from treatment? Just to show some of the complexities of cervical cancer or cytology-based treatments, you have lots of different supplies to really obtain the sample. Visual inspection after acetic acid is much simpler. You need a speculum and then just basic white vinegar and cotton balls that soaked in vinegar that are applied to the cervix to look for these lesions. One of the other things I just want to bring up is thermoablation is a treatment where you have this probe that's put against the cervix, and there's this sort of heat that's applied, which will ablate the cervix. It takes about 5 minutes. It's generally well tolerated, a simple procedure. However, women with HIV tend to have more extensive lesions that are not amenable to treatment with thermoablation. And so these women need a surgical procedure called LEAP or LETS, which can be much more complicated. For example, here you see in this middle panel on the top, this is an iodine stain, and there's this yellow area on top, and that's an area that would need to be treated. And so with the LEAP, they treat and remove and cauterize the cervix to remove this entire squamocolumnar junction to really reduce the risk of developing invasive cancer. But does require, injection. It has to be a trained medical provider that performs it. There's a lot of barriers to implementing this on a widespread basis, but it is the more effective treatment to treat cervical cancer precursors. Okay, so to talk about one of our specific projects, it's part of this Cascade network. And so this is a network of research bases. So we have one of the research bases here at UCSD that designs clinical trials in this area. There's also a set of 7 sites, clinical sites that will perform the studies in a central coordinating center. But just to say what the areas of focus, so one is screening uptake. How do we engage women with HIV in cervical cancer screening more effectively? The area that we're involved in is how do we manage screen positives? So if someone is screened, has an initial screening test that's positive, how do you choose and pick out the women that would benefit most from treatment? How do we increase access to precancer treatment? And then how do we improve our precancer treatment outcomes? So kind of lofty goals, but it kind of goes through the whole cascade of cervical cancer prevention to try to perform larger scale trials to really inform how we optimize cervical cancer prevention. So one thing that we're doing is we're focused on women that are screened with a primary HPV test, and then how do we use the results of the test to understand who to move on to treatment. So here on the right is an algorithm from the WHO. So HPV DNA testing. I will say for the most part in low and middle countries, the strategy that's being pursued is vaginal self-swab. So a woman self-sampling to collect the HPV sample that would then be used to determine whether she would move on to treatment. I will say on a side note, there are other options that are also being considered. There's some good data on using urine samples to be tested for HPV. We've chosen to use HPV vaginal self-sampling as our primary screening test. So if a woman's positive, we are using a test that has extended genotyping. So remember I said that there's 14 different HPV types. And so many of the assays now break these 14 different types up into different buckets of HPV. And these different buckets of HPV have a propensity to cause precancer and cancer, or a differential propensity to cause precancer and cancer. So HPV 16 and 18, as we said, that causes about 70% of cervical cancers. So really, the algorithm is pretty clear. We just manage these women with treatments in these areas. So if they are appropriate for thermal ablation, they get that treatment. If they require a more extensive treatment with LEAP or LETS, then they would be referred for that. So what's not known and what we're focusing on is what to do with the rest of the women that have high-risk HPV. So they have high-risk HPV, but not HPV 16 or 18. So these still cause at least 30% of cervical cancers, maybe even a higher proportion in women with HIV. And so currently the general approach is to use VIA to determine whether a woman needs to be treated. So she has HPV, non-16, 18 HPV, you do a VIA to look for lesions of the cervix. And then if there's a lesion, then you would go and follow these steps so that you would either treat with thermoablation or LEAP, depending on what you've seen. So one of the major issues is that VIA, again, requires a lot of quality assurance activities, ongoing, you should be looking at photos and making sure that the interpretation is correct. And really in practice, the sensitivity of VIA for these precancer lesions is much, much lower than what's actually reported in the literature. So what we're trying to do in our study is to say, can we take the information about HPV that we get from an HPV test to look at the different types of HPV that are present, as well as the amount of HPV. So we're using the cycle threshold. So this is, the HPV test generally all use a thermocycler. So the lower number of cycles it takes to get a positive HPV, the more HPV DNA is present. So if you're picking up a small amount of HPV, it takes many more cycles till you test positive. So we can use that cycle threshold as a surrogate or a marker of HPV viral load. And studies have shown that the higher amount of HPV, the more likely you are to have the cervical cancer precursors. This was studies that we did with colleagues in Johannesburg a number of years ago that used the expert HPV test result. So that provides, again, lots of different information, 5 different HPV results. And so one strategy that we looked at was if we were to say, just using the out-of-the-box HPV result as positive or negative in this study, and this was a number of years ago, so I don't think the HPV prevalence is as high now, but almost 2/3 of the women had a positive test. So you would be treating 2 out of 3. If you just went from HPV test to treatment, you'd be treating 2 out of 3 women. So really a huge proportion of women being treated. So what we showed that if you just restricted this instead of the 14 types to 8 types that were here, you could maintain reasonable sensitivity for cervical HSIL, but you could also reduce the number of women treated by a significant amount. And then on top of that, if we use the HPV DNA threshold, if we required a higher threshold of HPV DNA, then we could again maintain sensitivity and further reduce the number of women treated. So we could reduce the proportion of women treated by almost 1/3, and that would really focus the treatment on women at highest risk for having cervical precursor. So what we're doing in this is, well, we had proposed a study, but we actually are being asked to, because of a variety of reasons, kind of recraft this as more of a pilot study. But what we had intended to do was to test various management strategies for women that were tested positive for high-risk HPV based on genotypes and HPV viral load to really come up with a management regimen that would optimally identify women with cervical HSIL and reduce the amount of overtreatment for women that just had HPV without having HSIL. So we were planning a clinical trial of about 4,000 women with HIV from Botswana and Kenya who would undergo vaginal self-sampling. We were using a HPV test from Abbott that we were able to get donated, and really focusing on the women with non-16/18 HPV and randomizing them to different strategies to see what would be the most effective cervical cancer prevention management strategy. And so we did have a number of implementation science and a collaborator here at UCSD, Adrian Nguyen, was doing a lot of work on costing and microcosting to understand some of the relative economic trade-offs of these various strategies. So currently this is rapidly being redesigned as a pilot trial because we think we have another year of funding, but the additional years of funding are a little bit up in the air. So the strategy decision from NCI was really to focus on what we could achieve in the next grant year without, so really we would not be able to do the longer term study with longer term follow-up, but really more of a pilot study to support future trials, hopefully within this network, if all the funding issues can be worked out. The next thing I want to talk about is something that's further along. It's called ROSHA, Research on Oral and Cervical Cancer and HPV and HIV in the Americas. It's part of a ULEC net. It's a group of 3 U54 awards. That was really, the award was focused on Latin America and Caribbean. I was the MP or the contact PI at Cornell. Variety of reasons we left the grant at Cornell, but I'm now an MPI. And we've been doing 3 clinical trials. One of a 9-valent HPV vaccine to prevent oral HPV infection, and then a trial of various cervical cancer screening modalities, and then a pilot trial of a therapeutic HPV immunotherapeutic. So the studies, we'll talk about HPV vaccination in a second, so I'll just hold off on this one, but we're fully accrued and we're just waiting for all the number of endpoints before we can do the analysis. For the cervical cancer screening methods, we're nearly completed enrollment of 1,000 women from living with HIV from Brazil and Mexico. All of the women get HPV testing, stored samples for stored urine samples, stored blood samples. All of them undergo colposcopy and biopsies. Women with HPV who did not have cervical cancer precursor are seen at 6 months and a year to make sure that we identify if they're going to have incident cervical cancer or cervical precancer. But this will give us a big biobank of specimens to look at predictors of cervical H cells, so we could in the future test novel HPV screening or novel cervical cancer screening tests. For example, we're looking at DNA methylation, both host gene and HPV DNA methylation as a way to triage women that have high risk HPV to identify those at highest risk for cervical cancer. And then we're just starting this phase 1 trial that's actually be done in our US sites of an HPV immunotherapeutic that I won't really talk about today. All right, and then I'm sorry I don't have the collaborators for the Cascade network, but Rosha, it's certainly been amazing to work with such a tremendous team of people around the globe. And so we're excited to look to really analyze the results of those study in the coming year or two. So maybe, I don't know, let me just stop right here to see if we have any questions about this part. And then I can move on to some of the work that we're doing around HPV vaccination. I don't see anything in the chat, but if people wanted to unmute and ask any questions, we can do that.
Hi, Dr. Wilkin. Just curious, have you or has there been any research on folate intake and the prevalence of HPV in these countries at all? I know it's not a cure, but I know higher folate intake can be helpful.
You know, I'm not aware of that literature. I'm sure there would be some because, you know, obviously there's a lot of efforts for that supplementation, especially in terms of pregnancy.
I was trying to like quickly look for folate intake in South Africa, and I'm not sure if I can rely on ChatGPT here, but
Yeah,
I was wondering about.
that's always a good first step. Okay, I can move on to HPV vaccination. So just to start with what our current recommendations are, in the US, it's recommended the target age is 11 to 12. There's a lot of, it's approved down to age 9. And so there's a lot of efforts to try to get people to start HPV vaccination earlier to make sure we don't miss an opportunity. And then it's recommended for catch-up vaccination up to age 26. One area of controversy is really vaccinating people older than age 27 with HIV or just in general. It's not routinely recommended, but it's listed as shared decision making. And so the basis for vaccinating people up to age 45 was based on a study that enrolled women aged 24 to 45 with no history of cervical disease or genital warts, and then really looked at a per protocol efficacy of women that were negative for HPV and negative via blood tests, and then showed efficacy in that. For women that had evidence of prior infection, there was definitely reduced efficacy. So evidence that's supportive, but it's hard to know how this really applies on a population basis because this is just a very specific subset of people that have not really had HPV disease. So one area that we're studying in ULECNet is oropharyngeal HPV infection. So just a little bit about oropharyngeal cancer. So oropharyngeal cancer can be caused by HPV. There's also types that are caused by more alcohol and tobacco use. So depending on the country, about half to 70% of oropharyngeal cancer can be caused by HPV. So there's a lot of kind of supportive evidence that HPV vaccination will prevent oral HPV infection. There was a study, the Costa Rica vaccine trial, that looked at the bivalent vaccine, so preventing HPV 16 and 18. They did not look at oral HPV at baseline. They only looked at study exit. And what they found in the vaccine group, there was one case of HPV, oral HPV 16 or 18 in the vaccinated group, but 15 cases in the control group. In this case, they used hepatitis A vaccine as a control, suggesting that protection against HPV. I led a trial in the AIDS clinical trials group, and we looked at HPV, oral HPV prospectively. And when we looked at the endpoint of persistent oral HPV infection, we did find that there was one case in the quadrivalent HPV vaccine group as opposed to 8 cases in the placebo group. While sort of statistically significant, it was an incredibly wide confidence interval, so not what we would call a robust result. So that's really provided the basis for 2 ongoing trials of the 9-valent vaccine to prevent oral pharyngeal cancer. Merck is leading a trial that I've been fortunate to collaborate with them on, looking at the preventing oral HPV infection with the 9-valent HPV vaccine. So this is enrolling a bit older men. I think it's age, I can't remember if it was age 21 or 26 or older. And then in our ULECNet group, we've enrolled 700 men living with HIV, aged 20 to 50 years old in Brazil, Mexico, and Puerto Rico. And so we are currently, all the men have completed their HPV vaccination. We're waiting for the number of endpoints before we can analyze those results. And we're hoping we'll have the required number of endpoints in the next year or so. And so why this is really critical is that oropharyngeal cancer, as opposed to cervical cancer and anal cancer, we don't have any effective screening modalities at this point. There's a lot of work being investigated for looking at oral HPV or looking at antibodies to HPV over time. But at this point, we don't have any effective screening tests. We can't really identify the pre-cancer lesion for oropharyngeal cancer. In the cervix, we can take a biopsy, we can find cervical pre-cancer, know where to treat to prevent invasive cancer. But for oropharyngeal cancer, we might be able to identify a population at high risk for developing oropharyngeal cancer, but we would really have to try to screen and find the cancer at a very, very early stage to actually be able to intervene upon it. So for a number of reasons, a vaccine to prevent oropharyngeal cancer is really needed to really make a dent. And one other important fact about oropharyngeal cancer is and why we enrolled men is that there's about five-fold higher or incidence of oropharyngeal cancer, HPV oropharyngeal cancer in men as compared to women. And so women are already highly targeted for HPV vaccination around the world because of cervical cancer, but many countries don't include boys in their HPV vaccine programs. So this would provide really strong support to do so. Some of the other things that are coming along in HPV vaccination is there's a lot of work now around single dose of HPV infections, the Ken-Shi study. So at least over the short to medium time frame, single dose of HPV infection or HPV vaccination appears to be as effective as a full dose HPV vaccine schedule. So this has huge implications. And many countries have already moved to single dose approaches with the thought that they would, with the same amount of resources, they'd be able to vaccinate and protect a much larger group of individuals. There are some investigational vaccines that actually target even larger numbers of HPV types. So instead of 9, targeting, 12, 14 different types of HPV. And I mean, at least until recently, there was a lot of movement towards looking at other HPV-specific vaccine targets, basically targets that would perhaps target people who are already infected to improve outcomes and promote clearance of HPV and prevention of invasive cancer. So there's hopefully still a lot of interest in pursuing that. One other study I just wanted to talk about that's almost done with follow-up is AIDS Malignancy Consortium 099. So for this study, we hypothesized that HPV vaccination could improve responses to treatment for cervical precancer and HPV infection by protecting the cervix against new HPV infections and improving overall treatment outcomes. So we are conducting a randomized placebo-controlled trial at 5 sites across sub-Saharan Africa. We've accrued 536 women with HIV. We enrolled women that were 25 years or older and had certain types of HPV that were more likely to be associated with cervical HSIL. And then, so we hypothesized that these antibodies induced by vaccination would protect the healing epithelium from reinfection. And so we're looking at to see if the rates of HSIL are decreased among women that who've received HPV vaccination, women that are undergoing an HPV test and treat strategy for cervical cancer prevention. So what we do, we assess women for eligibility. They had expert testing in the clinic, as well as cytology and stored HPV samples. If they came back with these HPV tests that were at higher risk for cervical HSIL, they were eligible for the study, and they were randomized to vaccine or placebo. So they got the first vaccine at entry, they came back a month later, got the second vaccine, and then got treatment, either cryotherapy or LEAP, depending on the extent of the lesions. And then they came back for a third vaccine at week 26, and this is when we started histology sampling to look for endpoints. And then we also saw them at week 52, 78, and I don't know why this didn't capture week 104. So this was quite a challenge to accrue for a variety of reasons, COVID and other things, but we are fully accrued. And in fact, the 2-year follow-up ends in October of this year, so we'll be able to analyze these results. And the reason I wanted to bring this up is that we do have a number of stored specimens from this study, and pretty good. We'll have central pathology reviews, or pretty well annotated study population that could serve the basis for future grant applications. All right, so just basically for the vaccine, this wasn't really the focus, but hopefully everyone's advocates for HPV vaccination. There's incredible work that can be done about how we roll out HPV vaccination in different countries around the world. Some countries have already solved it. At one point, Rwanda, for example, had over 95% vaccine coverage for girls. And so, especially with the option of single dose, hopefully there's really going to be sustained efforts to have high vaccine coverage rates, especially in areas that don't have cervical cancer screening options. Yeah, and we'll continue our work on optimizing cervical cancer prevention in low and middle income countries and really trying to scale up these efforts. Anyway, so let me just stop there and see if there are additional questions.